Hi, this is Brian Kim. I want to share with you case number 181 in the Best Way to Do Cataract Surgery series. This is a 2 to 3 plus dense lens, fairly dense lens. You're going to see double chop, cross chop, mechanical fracturing techniques, as I always do. You're going to see the left heminucleus is stuck in the subincisional area. And you can turn the lens and you can try to do all sorts of things. You can see me rehydrodissecting, but this is going to be a cool maneuver I'm going to do, and I'm going to show it to you right now, and why I believe using the chopper to hook the peripheral lens pieces is so important and such a vital technique to go from a good cataract surgeon to a great cataract surgeon. So I use a corneal marker, which will help me to center and size the rhexis. And then I'm using my paracentesis blade first on the right side and then the left side, using the cotton tip to control the eye, making sure I turn the eye away from me when I make my incision, making sure the incision is flat to the iris plane, which creates a nice corneal shelf and which will allow me to achieve a self-sealing incision. And this is intracameral lidocaine and then some now intracameral epinephrine. Now I've noticed that the incision is not quite where I want it to be. So I made a new incision and I'm going to use that incision for the surgery. And so this is dispersive viscoelastic. So remember, if you have an incision you don't feel comfortable with, in this case I felt like it was too close to me for my main incision, I went ahead and made a separate incision, and then I went ahead, and this is a triplanar corneal incision. I make a vertical groove, place the blade into the groove, tunnel, and then enter, using the cannula to control the eye with that particular maneuver. And this is the sharp tip Haldi-Perkar forceps. I puncture the center of the capsule, pull down towards me, sweeping to the right side, grabbing the right side of the tear. And again, because I'm able to titrate the tear, I'm able to titrate the size of the rhexis, going around circumferentially. Again, using that corneal marker that I made, that corneal mark that I made as a guide for the size and centration of the rhexis. Burp some viscoelastic out, and this is the capsular fornix hydrodissection technique. I place the cannula under the rhexis edge contra-incisionally, point the tip down into the equator, get a nice wave. And then I'm going to decompress on the left side, sweeping under the rhexis edge, pushing some BSS as I do this on the left side, and then doing the same maneuver on the right side. You can see that the lens is rather stubborn. It's not really wanting to spin. And I did a little bit of hydrodelineation there as well. And so again, when you have a lens that doesn't want to spin, again, it's a sign perhaps maybe some weak zonules. Even though there is good hydrodissection wave, sometimes the lens just doesn't want to go. And you're going to see how that's going to play into the lens disassembly and how it's going to hinder the lens disassembly and how I overcome this. Irrigate the surface of the eye, lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material, leading with the chopper on pronated, place it at the equatorial side, turning it vertically, placing the phaco tip vertically subincisionally, fracturing the lens completely in half, that's double chop, turning the chopper again, pronating, placing it around the right heminucleus, pulling it centrally toward the phaco tip, fracturing the right heminucleus against the phaco tip. Again, the phaco tip is acting like a chopping block. Lifting that first quadrant up with some vacuum, crushing the lens between the instruments, and then emulsifying the lens piece. So I'm going to show this again in half speed, again leading with the tip of the chopper, sliding it underneath the rhexis edge, getting it out to the equator, rotating it vertically, and then taking the phaco tip vertically subincisionally, stabbing the lens, and then bringing the instruments towards the center. Again, I have opposing forces on either side of the lens, crushing it essentially, crushing the lens. It's not really chopping, it's just mashing the instruments together to crush the lens. Rotating and pronating my hand and then sliding it underneath the right heminucleus, underneath the rhexis edge, pulling it centrally toward the phaco tip, fracturing the lens piece against the phaco tip, and that is, again, cross chop. Again, I'm pulling the chopper towards the phaco tip, and the phaco tip is acting like a chopping block. I lift that first quadrant up with some vacuum, getting around it with the chopper, and then crushing the lens into smaller and smaller pieces, and then emulsifying the lens piece. Again, using pulses of ultrasonic energy and vacuum in the process. By doing it this way, I utilize less ultrasonic energy, maximizing mechanical fracturing forces to break the lens piece up rather than using too much ultrasonic energy in this situation. Using the chopper to tease that second quadrant away from the rest of the lens, getting around the lens at the level of the equator, pulling it central toward the phaco tip, fracturing the lens completely in half. Again, Because I'm able to place that chopper around the lens at the level of the equator, I'm able to hook the peripheral lens, pull it centrally toward the phaco tip, fracturing the lens against the phaco tip. Again, the phaco tip is acting like a chopping block. Using the instruments to, again, crush the lens into smaller and smaller pieces, and then emulsifying the lens piece. So this is the cool part, okay? I'm trying to turn the lens. The lens doesn't want to turn. So I can push on the zonules and cause problems. Yes, I can hydrodissect, but look at this cool maneuver that I've developed here, okay? Taking the chopper, get underneath it, getting between and underneath the rexus edge there, turning the tip and rolling it, and I'm able to pop that lens up out of the bag. And once I do that, I get the instruments around it and I fracture the lens completely in half. So I'm able to fracture the heminucleus from the subincisional side. No rotational stress, no zonular stress, no struggling to turn the lens. Again, so many people are so reliant on having to rotate the lens within the capsular bag. If you have better techniques, more efficient, more versatile techniques, you don't have to do all that. And even though you have a lens that doesn't want to spin, even though I did good hydrodissection, you can see how I'm able to tackle these cases and have absolutely no fear or worry that I'll be able to disassemble this lens and get it out of the eye. Again, all because I am confidently and carefully placing that chopper around the lens within the capsular bag. So here now, there's some stubborn epinuclear material. See what I'm going to do now? I use a chopper, slide it underneath the epinucleus, sweeping it into the subincisional area. Again, I have active irrigation, so I know the bag is inflated, and I'm very easily, confidently hooking the peripheral epinuclear material in the subincisional area. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. I start subincisionally removing the cortical material. Again, this is a fairly dense lens. You can see the CDE is around 2.5 or so. Start subincisionally removing the cortical material from anterior to posterior, peeling it in this way, and this provides a more clean peeling of the cortex off the capsular bag. You can see there's a little bit of zonular laxity as I pull that cortical material off the bag, and that's what I sense there. Again, part of the reason why probably the lens didn't spin quite well. So I switched to polish mode, polishing underneath the rexus edge, removing the lens epithelial cells. Because of the polymer tip and the low flow sittings, I can polish into the capsule fornix confidently and safely. I'm able to polish the posterior capsule as well of any fine lens material. And that's the nice thing. You can go to the subincisional area, peel off that material off the posterior capsule, switch to cortex mode, and then remove the rest of that cortical material off. So I use the BSS cannula to pulse into the subincisional capsule fornix. You can see there's some fine lens material that's coming up. You can see it right there. And then using the INA tip to go after it. Turning off irrigation, and then pushing cohesive viscoelastic to fill the capsular bag. And this is a sweep. I'm going to start to sweep into the subincisional area as well and removing the lens epithelial cells. And cleaning all that stuff is really, I think, very important to have a cleaner bag, less inflammation, reduce PCO. And again, in the future, if you needed to exchange the lens, much more easy to do that. Placing the single piece acrylic lens into the capsular bag, delivering the leading haptic into the bag. As the lens unfolds, I go in with the INA handpiece with irrigation off, activate irrigation, making sure the haptics come off the optic, rotating the lens 90 degrees clockwise, getting underneath the lens, removing all the viscoelastic from within the bag. Switching to polish mode and then visco mode, removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, You saw that this was a fairly dense lens, made 2 to 3 plus dense lens. I performed double chop, cross chop, very efficiently disassembled the lens. But you saw two things. The left heminucleus was stuck, it didn't want to turn, and you saw that even though I had good hydrodissection, the lens didn't want to spin. I was able to hook the peripheral lens, getting underneath, around the rhexis, within the rhexis edge, getting the chopper in the subincisional area, rotating it, I was able to pop that lens up, that nuclear piece. Very efficient, very safe. I'm using just my instrument to hook the lens. I didn't have to rotate the lens and then put traction on the zonules. Yeah, I could have used another wave of hydrodissection, but that would have been another step. But just using my same instrument, the chopper, which I use so liberally around inside the eye, because why? I trust myself with the chopper. There's no high vacuum, there's no ultrasonic energy. Those are things that are out of my hands. It's like having a jackhammer or a very sharp instrument. You know, you're wielding it and you're throwing it around. You know, there's something that can happen if you hit something wrong. This is really almost like a wet noodle. I mean, it's very safe in contrast to the phaco tip. And so after I was able to pop that lens piece up in the subincisional area, that second heminucleus, I was able to fracture it in half. And then there was some stuck epinuclear material as well in the subincisional area. I was able to get around it with the chopper. Again, the bag is inflated. I'm not putting any traction on the bag. And I was able to pop that epinuclear piece up again without going after it with high vacuum. So again, the chopper is really the single most important instrument because you're able to hook the peripheral lens very confidently at the level of the equator. Again, you have to be sure that you know what you're doing, and you have to make sure that you're within the capsular bag when you do that. And of course, utilizing the phaco tip as a secondary chopper and knowing how to use it as a chopping block for that chopper. And by doing it this way, you're able to chop at so many different angles. It's such a versatile way to do cataract surgery. And as you can see, the way I do cataract surgery, this is why I'm so passionate about and believe wholeheartedly that this is the best way to do cataract surgery, by utilizing mechanical fracturing forces, crushing the lens pieces, and using and leveraging that chopper to pull lens pieces up out of the bag, not just lens pieces that are away from you, but in this case also lens pieces that are under you, again, which is kind of not the way you normally think about using that chopper. You saw an example of two cases where I was able to hook the subincisional endonucleus as well as the subincisional epinucleus very confidently and safely. So I hope this was helpful to you, and I thank you for your attention.